Committee will come to order. We are awaiting some of our witnesses that were caught up in traffic this morning, also in security outside the building, but they will be here momentarily. Before we begin our hearing this morning, I'd recognize Mr. Takano to talk about recent impacts in California events of last night. Mr. Takano.
Thank you, Mr. Chairman. My district, the 41st District, is based in Riverside County, and the largest city within my district is the city of Riverside. And I would like to offer a moment of silence for Officer Michael Kane of the Riverside Police Department, who was shot and killed last Thursday by former LAPD officer Christopher Dorner, and for the three other victims of Dorner's violence. Prior to his service with the Riverside Police Department, Officer Crane served in the United States Marine Corps and was deployed for 2 tours in Kuwait as a rifleman. He was awarded multiple honors for his bravery, so I would ask the committee to take a moment of silence to honor the memory of Officer Kane and the 3 other victims, 3 others whose lives were needlessly taken, and their families.
Without objection, the committee will pause for a moment of silence. Thank you, Mr. Takano. Our thoughts and prayers are with you and your constituents and their families.
Thank you, Mr. Chairman.
Thank you very much. Thank you, everybody, for joining us this morning for the first full committee hearing of the 113th Congress, honoring the commitment, overcoming barriers to quality mental health care for veterans. It's only fitting that we would start with this hearing today as we begin our oversight by addressing what I think is one of the most pressing and fundamental issues facing our service members, veterans, and their families, and that's the ability to provide timely and effective mental health care to veterans who need it, when they need it. This issue is not a new one, but I think everybody will agree that it is a growing issue. In the last 6 years, there's been a 39% increase in VA's mental health care budget and a 41% increase in VA's mental health care staff. Unfortunately, these significant increases have not resulted in equally significant performance and outcomes. Now, less than a year ago, the VA Inspector General released a review of veterans' mental health care access that painted a disturbing picture, showing that the majority of veterans who seek mental health care through VA wait 50 days on average for an evaluation. That figure amounts to thousands of veterans in need, veterans who have recognized that they need help and who have taken the hard step of asking for that help, being told by a federal bureaucracy tasked with caring for them that they can wait in line because the VA cannot provide them with timely access to the care that they need to begin their healing process. And it only gets worse. Earlier this month, VA released its 2012 suicide data report. The report shows, among many alarming findings, that the suicide rate among our veterans has remained steady for the past 12 years, with 18 to 22 veteran deaths per day since 1999. As that report so clearly illustrates, when a veteran is in need of care, the difference of a day or a week or a month can be the difference between life and death. This morning, the department is going to testify that progress is being made to increase access to mental health care services and reduce veteran suicide. I think they're going to proclaim that they have hired just over 3,200 additional mental health care personnel. However, despite our request, VA has yet to provide evidence to verify its efforts. While I am and will remain supportive of the improvements that the department is attempting to make, it has become painfully clear to me that VA is focused more on process and not on its outcomes. The true measure of success with respect to mental health care is not how many people have been hired, but how many people have been helped. Since 1999, their mental health care programs, their budget and staff have increased exponentially, and the number of veterans seeking care has grown. Yet the number of veterans tragically taking their own lives is still the same. What's more, the suicide data report that I mentioned earlier shows that the demographic characteristics of veterans who die by suicide is similar among those veterans who access VA and those veterans who don't access the VA system. Something somewhere is clearly missing. On our first panel this morning, we will hear from representatives from our veteran service organizations, an established veterans mental health researcher, and a state commissioner of Veterans Affairs. 3 of them are veterans themselves, and all of them will testify that the provisions of mental health care services through VA is seriously challenged, and that what is needed is to fix what is needed to fix is decidedly not more of the very same thing. Last night, the President announced that a year from now, 34,000 of our service members currently serving in Afghanistan are going to be back home. The one-size-fits-all path that the Department is on leaves our returning veterans with no assurance that current issues will abate, and fails to recognize that adequately addressing the mental health needs of our veterans is a task that VA cannot handle by themselves. In order to be effective, VA must embrace an integrated care delivery model that does not wait for veterans to come to them, but instead meets them where the veteran is. VA must stand ready to treat our veterans where and how our veterans want to be treated, not just where and how VA wants to treat them. I can tell you this morning that our veterans are in towns and cities and communities all across this great land, and the care that they want is care that recognizes and respects their own unique circumstances, their preferences, and their hopes. I earnestly appreciate all of you being here today, and I yield to our ranking member, Mr. Michaud, for his opening statement.
Thank you very much, Mr. Chairman, for continuing to keep the issue of access, quality, and timely mental health services provided to our veterans at the forefront of this committee. And thank you to all of our witnesses today for coming and talking with us about the critical issues of veterans' mental health access. I'd also like to thank all of you in the audience who are here today for your continued support for our veterans population. We as a nation have a responsibility, a sacred trust, to care for those whom we send into harm's way. When we send our citizens into battle around the world, we must be leading the charge here at home, within our government, to make them whole again upon their returns by ensuring that adequate resources and proper programs are in place to address their needs. Oversight of the VA's mental health programs have been a focus of this committee for some time now. Over the years, we have held numerous hearings, increased funding, and passed legislation in an effort to address the challenges of our veterans from all eras. VA spent $6.2 billion on mental health programs in fiscal year 2012. I hope to see some positive progress that this funding has been applied to the goals and outcomes for which it was intended, and the programs are really working. We all know that mental health is a significant problem that the nation is facing now, not only in the VA, but throughout our population. And the broader challenges is an opportunity for the VA to look outside of their walls to solve some of the challenges that they face. rather than operate in a vacuum as they sometimes have done in the past. One of the most pressing mental health problems we face is the issue of suicide and how to best prevent it. Fiscal year 2012 tragically saw an increase in military suicides for the third time in 4 years. The number of suicides surpassed the number of combat deaths. Couple that with the number of suicides in the veterans population of 18 to 22 per day, and the picture becomes even more alarming. I believe VA is heading in the right direction. I believe that they have made a true effort to get a good picture of the suicide issue that surrounds veterans, but I believe a lot more can and must be done. I will be interested to hear from our panelists about the national mental health picture and helping this committee put the veterans' suicide rate in context, as well as what is happening nationally in treating mental illness. Today's hearing will examine the progress VA has made in a variety of areas concerning mental health and providing timely access and quality care. I'm hopeful that this will be a good discussion on ways to provide the care, such as more partnering with the public and private sector, increasing the pool of providers, and other creative ways to address mental health issues. And finally, I would be remiss if I did not acknowledge the dedication of the VA employees for providing quality mental health care to our veterans every day. The directors, nurses, doctors, hospital workers are a team, and I want to thank them for all that they're doing. But we have to do a lot more. As you heard the chairman talk about the president's speech last night with our soldiers that are going to be coming back from Afghanistan, I do not know how many of those soldiers are going to be Guard and Reserves that will be going back to rural areas. Access and quality and the timeliness that our veterans will need to address these mental health issues, and we definitely do have to think outside the box to make sure that they do get the help that they need when they need it. So with that, Mr. Chairman, once again, I want to thank you for your dedication, your commitment, and your willingness to keep this issue before the full committee so we can make sure that our veterans get the help when they need it. Thank you, and I yield back.
Thank you very much to the ranking member. If I could invite the first panel to the witness table. And as you are making your way forward, I would like to introduce the witnesses to the members of the committee. First, Dr. David Rudd, Dean of the College of Social and Behavioral Sciences and co-founder and scientific director of the National Center for Veteran Studies at the University of Utah. We also have Dr. Linda Schwartz, Commissioner of the Connecticut Department of Veterans Affairs. Dr. Schwartz is also a Vietnam veteran, having served on active duty as a reservist for the United States Air Force. Dr. Schwartz, thank you for your service. They are joined by Joy Elam, the Deputy Director of Legislative Affairs for the Department of Disabled Veterans of America, Ralph Ibsen, the National Policy Director for the Wounded Warrior Project. Ms. Elam and Mr. Ibsen are both veterans of the United States Army. Thank you for your service. I want to again say thank you all for agreeing to appear this morning. This committee is uniquely interested in what is going on. I would say that there are numerous members that are doubled up right now in an Armed Services Committee hearing as well that deals with the continuing resolution and sequestration, so their absence here does not affect the fact that they are very interested in this issue, and they will be coming in and out as the hearing progresses. So with that, Dr. Rudd, please proceed with your testimony, sir.
Mr. Chairman, Mr. Ranking Member, members of the committee, I want to thank you for the opportunity to speak with you here today. You have my written testimony. I'm not going to read that testimony other than just comment and emphasize a number of points that are embedded within the testimony. If we look at this problem over the course of the past decade, I think it is critical that we put it in context, that we understand it within context. And I think a starting point for understanding the trajectory of this problem over the course of the last 10 to 11 years is to recognize that prior to Iraq and Afghanistan, service in the military was a protective variable to suicide, that the suicide rates for young men and women of comparable ages were about half that of the general population. So prior to these wars, things were different. Things have changed. There are many of us that would speculate about what that is. I would tell you it probably is related to pre-enlistment screening, how we handle screening. It's probably related to issues of unit cohesion. The 10 to 11 years of war impact and affect unit cohesion in very profound ways. I've talked with many soldiers and service people about that very issue. The influence of purpose, that 10 to 11 years of war affects your sense of purpose, and ultimately the sense of warrior identity that we find in soldiers today, which is profound, and I'll talk with you a little bit more about later. As a starting point also, let me applaud the transparency and the thoroughness of the VA suicide data report. Dr. Kemp is with us, and I would tell you that the effort is genuinely historic. This is something that we should have done decades ago to fully understand, be able to track and monitor the problem. We have to have a system in place to genuinely understand the problem. This is a first effort to genuinely understand the nature of the problem, have accurate data that can actually inform policy and inform decisions. I think it's simply an exceptional move on the part of the VA, and very glad to see that. Now, when I say that, I think it's critical that we put these rates in context. When you look over the course of the last 12 years specifically, that if we look at the death rates by suicide for veterans, if you look at those death rates of VHA service users, those rates are triple the rates for the general population. They're double for the male population, and although that comparison is a little bit clouded given the nature of the two populations, if you look at the age-specific data for the VA, I think it's important to understand that the 18 to 34 year age group, that the rates are double that of comparable young males in the general population, that risk endures, and I would suggest that in very specific ways that is probably linked to active duty risk over the course of the last 10 to 11 years. And it's a significant problem that we need to think about. Starting to conceptualize this as a continuum from active duty risk to transition to veteran status, and the endurance of that risk for the first decade to decade and a half of veteran status is an important thing for us to look at. As a result of these persistence, the persistence of risk over the course of the last 10 to 12 years, and the better the data we have, it seems more clear that the risk endures. I would very much agree with you, Mr. Chairman. It's time for us not to do the same thing, that more of the same simply isn't working, that when these rates endure at the high levels that they are, that funding more of the same is not the route to go. A couple of other points I'd like to make about the report. I think it's a significant move in terms of establishing, maintaining, and monitoring the crisis line. I find that a wonderful wonderful addition. I would encourage you, though, that we may not be reaching the right population, that the drop from 40% to 30% of the callers in terms of individuals that identify themselves as suicidal may mean we're not reaching the right group. We've got to think about different ways of reaching those individuals. And finally, I want to share briefly with you a story that I think is probably symptomatic of the problem. I've included it in my testimony. I'm not sure that this is a clinical problem. I think it's a management. I think it's a systemic problem in terms of how we handle individuals that are at risk. And I've included in my testimony the tragic suicide of Russell Shirley. I spoke with Russell's mother over the course of the last month. I've spoken with one of his dear friends. And I think Russell is probably typical of the problem, the tragic problem which will occur over the coming years. Russell was a son, a husband, a father. He was a soldier. He served his country proudly and bravely in Afghanistan. He survived combat. He came home struggling with PTSD and traumatic brain injury. With a marriage in crisis and escalating symptoms, he turned to alcohol. He received a DUI, and after 10 years of dedicated service, he was discharged. And part of the rationale for the discharge was the increasing pressure to reduce the size of the force. I think we're going to see more and more of that over the coming years. After the loss of his family, the loss of his career, and the loss of his identity, Russell shot himself in front of his mother. Having spoken with Russell, I would tell you, or having spoken with Russell's mother, I would tell you that a part of the tragedy is that we knew that Russell was at risk prior to his death. We recognized, identified him as an at-risk soldier prior to his discharge, but yet there are not adequate transitional services in place that allow a clean connection from an individual to an individual. And I think those are the sorts of things that we need to start talking about. We need to start thinking about how do we connect at-risk soldiers once we identify them and they're being discharged, particularly if they're being discharged against their wishes, into a VA system, and how do we connect them with an individual and not just a system? How do we help them connect in a relationship that can potentially save a life? I've included a picture of Russell with his two children at the end of my testimony, and the reason I've done that is I think it's important for all of us. When I read the suicide data report, the one thing that is missing in the suicide data report are the names of the individuals, the names of the families, the names of the loved ones that are affected and impacted by these tragic deaths. And I think it's important for all of us to remember that. Thank you very much.
Thank you, Dr. Schwartz.
Good morning, Mr. Chairman, and good morning, Congressman Schode. I'm Linda Schwartz. I'm the Commissioner of Veterans Affairs for the state of Connecticut. As the Commissioner, I've been a Commissioner for 10 years. I'm serving my third governor. I am responsible for 277,000 veterans in our state. I have a 75-bed substance abuse treatment recovery program. I have a chronic disease hospital. I have the second largest domicile in America, which has today 380 veterans in residence. I have 3 cemeteries and 5 district offices. I'm here to kind of echo what was said by Dr. Because let me just say this. When you talk about the suicide, let us be clear. Let us be clear that no death index is going to have accurate information. In my experience, we were looking at suicides because it was a very important thing. So I started, because I have 3 cemeteries, I look and see what are the causes of death. And many of these deaths are not declared suicide out of respect for the religious beliefs of the individual, for the family, or because no one wants to make that call. The reason it is so shocking is because it is secret, and many of the things that are going on with our reserves and our Guard are not talked about openly. So I applaud the VA for at least making an attempt to quantify. But I also would like to move to the state of Connecticut, where for the past 25 years, our Department of Mental Health and Addiction Services has been asking, have you ever served in the military? They've been asking, are you a veteran? Interestingly, we didn't quantify this till the late 90s. I was a public health nurse at the time, so I was checking off those boxes. We had 5,000 veterans on the rolls of our state Department of Mental Health and Addiction Services. And even though we have had the opening of community-based outpatient clinics and vet centers in the state of Connecticut, those numbers have not changed significantly. We still have about 5,000 veterans receiving their care from the state. I have referred to the reasons why. Most of it in my testimony, but the proximity, access to care is a lot more than being eligible for your VA benefits. It means that if your closest VA hospital is 65 miles away and you're having a crisis, you want somebody in your community, you want somebody who's going to listen. Additionally, VA provides wonderful services, but you do not have access to your care provider 24/7 like somebody in private practice. My master's is in psychiatric nursing, so I have had the experience of working with mental health patients. But I would just like to say that I'm just going to skip the President's message last night that we're going to have all of these people coming down. He mentioned a very important part. Some of these people joined. You have an all-volunteer force who has joined. They intended to make this their career, and now you have a drawdown, and that is a loss of identity. As a disabled veteran, I had to leave military service, and I had a long time finding a new identity. But I want to go quickly to what Connecticut is doing today, because I believe it addresses some of the issues that others will raise. In 2005, we set aside money in our budget, and the legislature enacted legislation that we would set up a program for veterans, mostly at that time Guard and reservists, who would not be covered by VA services. We trained medical professionals who are living in the community. We used a model that came out of 9/11, that Connecticut was tasked with a lot of mental health needs, so doing some training with people that are already in practice, already have their credentials, already have their professional requirements. We gave them 16 hours of what we called Military 101. We have a 24/7 hotline. Anybody in the state of Connecticut, whether they are the military member, the spouse, the children, the parents, the significant other, are eligible for this program. If you call that number right now and you say, I live in Pawcatuck, Connecticut, and my husband is going sailing every morning with Captain Morgan, what should I do? They will tell me who in my geographic area has gone through this training and is part of that network. And to be part of that network, the professional has to agree that they will contact that individual who makes that call through the client from the military support program. They must contact them within 48 hours. This is open because many of the providers do not charge. However, the state of Connecticut has authorized 15 sessions within a calendar year for all of these family members. I did cite in my testimony that in Maine, they did a study where they found out that many military members are more likely to go to treatment with their family because it does decrease the stigma. The military member can say, I'm doing this for my family, and everybody will say, that's a really great thing you're doing. And we hope and we know that they are also receiving their care and some help too. I realize my time is almost out, but I want to say something very important to all of you. The states, each one of your states has someone like me, a director, responsible to the governor and the people of your states to take care of your people. States collectively put $6 billion on the table every year to take care of veterans. The VA is a vast system which cannot really meet the demands of the way we're doing war with our reservists and our guards today. So the most important thing that we are looking for is a little help from the federal benefits and grants. Too much emphasis is put on having people go for health care where you have eligibility requirements. We have to look to the veteran benefits side of this for outreach, for training for those individuals who will be the service officers that develop these claims. And although the VHA has a very robust and very good grant system, you need to look at having the Veterans Benefit Administration also be able to provide grants to support this. Can you imagine where I give high marks to Secretaries Shinseki and Hickey because they have done a lot to electronically do the records. But when it gets down to where the rubber meets the road, it's the person who's taking the claims, it's the person that's pressing the button. I have 10 service officers. Some of them are Vietnam veterans, and they still feel that if they have to touch the computer, they'll become electrocuted. So this is a knowledge gap that is very, very essential. I thank you so much, really, for giving me a little extra time. But if you don't remember anything else I said today, VA cannot do this by themselves. You have many good people in each one of your states that wants to do a good job for your veterans, all veterans. It's time to really look about formalizing the partnership between your states and the federal VA. Thank you so much.
Thank you very much, Doctor. We appreciate all of our states and our territories for doing what they do in partnership for our veterans. We appreciate your testimony. Next, Joy Elam from the DAV. You're recognized. Thank you.
Thank you, Chairman Miller and members of the committee. I'm pleased to present the DAV's views on access to VA mental health services. Like the committee, DAV is committed to fulfilling our promises to the men and women who served, and one of those promises is to ensure that veterans receive an opportunity to fully recover from physical and psychological wounds that occur as a consequence of their military service. Given the diligent oversight by this committee and the significant level of new resources that have been authorized to address the existing deficits and to improve VA mental health services, the current question posed by the committee chair is a valid one. Is VA's complex system of mental health care and suicide prevention services improving the health and wellness of our heroes in need? Over the past 5 years, VA's Office of Mental Health Services has made significant progress and placed special emphasis on suicide prevention efforts, launched an aggressive anti-stigma outreach and advertising campaign, increased peer-to-peer services, mental health consumer councils, and family and couples counseling and therapy services. Yet despite the noted progress, in our opinion, there are several core issues that are likely responsible for the continued mental health access issues that are plaguing VA. These issues have been the topic of numerous congressional and government oversight reports and include problems with VA's outdated patient scheduling system, reliability of waiting time data, proper staffing levels, and a mental health staffing model that accounts for shifting trends and demand for specific types of services. Many of these issues were addressed at the May 2012 hearing you held, and VA noted work was underway on several fronts and specifically that a prototype staffing model was being tested in 3 VA networks. Like the committee, we're anxious to learn whether VA can deploy this prototype throughout its system and whether it works well for mental health in particular. Likewise, we're eager to learn about the progress on the variety of other issues addressed in the various reports. Mr. Chairman, another topic you asked that we addressed was effectively partnering with non-VA resources to address gaps that create more patient-centered network of care focused on wellness-based outcomes. In this regard, you endorsed a VA TRICARE outsourcing alliance to serve the mental health needs of some newer veterans that VA is admittedly struggling to meet today. We urge VA to work with the committee to ensure that if mental health care is expanded using the existing TRICARE network or some other outside network, veterans receive direct assistance by VA in coordinating such services, and that the care veterans receive will reflect the integrated and holistic nature of VA care. When a veteran acknowledges the need for mental health services and agrees to engage in treatment, it is important for VA to determine the kind of mental health services that are needed and whether the most appropriate care should come from a VA provider or a community-based source. This type of triage is absolutely critical because high-quality, effective mental health treatment is dependent on a consistent, continuous care relationship developed between the veteran and the provider. Once a trusting therapeutic relationship is established, that connection should not be disrupted if possible. Mr. Chairman, DAV previously testified that in our opinion, our newer veterans can particularly benefit from VA's expertise in treating coexisting PTSD, substance use disorders, traumatic brain injury, and other post-deployment transition issues. To that end, it is essential that VHA address and resolve the barriers that obstruct consistent, timely access to care at VA facilities nationwide. However, if a veteran is referred by VA to a community resource, we urge that care be coordinated by VA. A critical component of care coordination is health information sharing. The absence of obtaining health information poses a barrier to implement good patient care strategies such as chronic disease management, prevention, and use of safe care protocols within VA. These are some of the principal flaws we see in VA's current approach in fee basis and contract care. We believe the policy changes made by VA's Office of Mental Health Services over the past decade are positive and ultimately equate to better patient care and improved mental health outcomes, but significant challenges are clearly evident and need continued attention. Unfortunately, the root causes for these existing barriers in VA's mental health delivery system are complex, system-based, and long-standing, and cannot be resolved by any single reform. Therefore, we urge the committee's continued oversight of VA's progress in correcting not only the internal processes and resolving the existing barriers that prevent some veterans from receiving the timely services they need to fully readjust and integrate following military service. I just wanted to say I really think what Dr. Rudd said really is a poignant point that we really need for veterans that are at risk. They need to be put together with an individual, a person, someone they connect to, and not just a system. So with that, I'm willing to answer any questions the committee may have. Thank you.
Thank you very much. I'd ask the panelists indulgence for just a moment while we recess the hearing and enter into a quick business meeting. And with that, I recognize Mr. Michaud for a motion.
Thank you very much, Mr. Chairman. I would like to offer a resolution adding Timothy J. Waltz of Minnesota as a Democratic member of the Subcommittee on Oversight and Investigations.
Thank you for that motion. Since we do now have a quorum, all in favor will say aye. Aye. Opposed, no. Motion carries. Welcome, Mr. Waltz, to the O&I Subcommittee, and thank you, Mr. Michaud, for your motion. Our business meeting is now adjourned, and we will take up the hearing again. Mr. Ibsen, you are recognized.
Thank you, Mr. Chairman. Chairman Miller, Ranking Member Michaud, members of the committee, let me also congratulate Mr. Waltz. For Wounded Warrior Project and those we serve, the issues raised this morning and the challenges it poses are profound. We greatly appreciate your scheduling this hearing and greatly appreciate your powerful opening statements. My organization's mission is to honor and empower those wounded since 9/11. And let me give you some context for the concerns we have. In a large survey of our wounded warriors last year, 69% of respondents screened positive for PTSD, 69%. 62% indicated they were currently experiencing symptoms of major depression. More than 2/3 of those surveyed indicated that emotional problems had interfered with work or regular activities during the previous 4 weeks. Some acknowledged getting help from VA therapists, but more than 1 in 3 reported difficulties in accessing effective mental health care. The feedback, in essence, was that VA is overwhelmed. I do want to acknowledge the hard work done by VA Central Office Mental Health Leadership, as well as the step VA took last year to increase mental health staffing. That step, though, is not a comprehensive solution. There is no single silver bullet out there in our view, because the system faces a range of different problems. One of the leading researchers in the field, Dr. Charles Hogue, has, I think, captured the scope of VA's challenge as follows. Quote, veterans remain reluctant to seek care, with half of those in need not utilizing mental health services. Among veterans who begin PTSD treatment with psychotherapy or medication, a high percentage drop out. With only 50% of veterans seeking care and a 40% recovery rate, current strategies will effectively reach no more than 20% of all veterans needing PTSD treatment. So the issue is not simply improving access. One has to ask, for example, access to what? Mental health care also has to be effective. At a minimum, that requires building a trusting relationship between provider and patient. And that trust can be quickly broken when a veteran, for example, who needs one-on-one therapy is simply offered medication, or when that same veteran is put into group therapy prematurely, or is only offered therapy that requires reliving the painful trauma of war when he or she is not ready for that level of intensity. Many of our warriors become frustrated and drop out of VA treatment, but many VA clinicians as well are also frustrated. Why? Because the VA system too often bars them from exercising their best clinical judgment. Instead, VA performance requirements dictate clinical practice. As one psychiatrist told me recently, quote, the number of required clinical reminders I get keeps growing. I have a patient who is homeless and whose wife has recently died, but I have to take time away from treatment to administer a depression screening test, even though I know the individual is depressed. Similarly, quote, I need to be able to spend enough time addressing the veteran's wife's recent death rather than being required to urge him to stop smoking, close quote. Sadly, a clinician who bucks the performance requirements in the name of exercising good clinical judgment can incur financial repercussions as a result. As one described it, quote, the reality is that the VA is a top-down organization that wants strict obedience, close quote. At best, these performance requirements measure processes, as you indicated, Mr. Chairman, rather than determining whether the patient is getting better. And as prior hearings have documented, these requirements are often circumvented or gamed. VA has acknowledged a need to improve mental health care delivery, but what seems to be missing in some instances is transparency. We'd wonder, for example, why, after conducting mental health site visits at 150 VA medical centers last year, VA has not provided this committee a detailed report of those findings. Last year, to its credit, VA conducted a survey of its mental health staff. Why have we not heard about the findings? Let's be clear, there are things that are working well in this system. The Vet Center program is one. Providing peer outreach and peer support, as VA has begun to do and is called for in the President's executive order, would be another one if it were launched in full and accomplished as intended. And again, let me emphasize that there are many well-intentioned, highly dedicated mental health staff at VA centers and clinics who are committed to providing good treatment. But more must be done, in our view, to close gaps in the VA system, close gaps between its promise and its on-the-ground reality, between policy and practice. Congressional oversight has been a critical catalyst in identifying the need for system improvement. I think there are also opportunities to break down what can be an adversarial relationship between a committee and a department, for greater partnership, for greater dialogue. I think as you suggested in your opening statements, there are different directions to be taken. There are opportunities, as Linda indicated, for greater partnerships between VA and states and between VA and communities. These are all steps that ought to be pursued. Vigilant oversight, again, must continue, and we stand ready to support in that effort. I'd be pleased to answer any questions you might have. Thank you.
Thank you very much, Mr. Gibson, and thank you for what the Wounded Warrior Project does as well. We appreciate, again, the testimony, and all of your complete written statements will be entered into the record without objection. I recognize myself 5 minutes for questions. Dr. Rudd, I was struck by your comment that we need to connect veterans in need, not just with the system, but with people within the system. And I think everybody here has said something very similar to that. I think it was important for us from a clinical standpoint to understand the need to connect personally, and the personal efficacy and the importance of choice within the mental health field. So can you talk a little bit about why it is so critical to connect on the personal level?
Oh, absolutely. If you look at, let's take, for example, the recent active duty numbers from this past year. So if we look at this, if we look at the recent active duty numbers from this past year, half of those individuals that died by suicide either were in treatment or had received care of some sort, either inpatient or outpatient care. If you look at the VA numbers from the report, you'll see that 80% of those individuals that had a non-fatal event, in other words, made a suicide attempt, were in treatment 4 weeks prior to the event. What I would tell you that both of those numbers reveal is the nature of how they're connected to care. That the problem, if we took the active duty numbers and took those, half of those individuals that tragically died, they remained in care and were effectively treated, the problem would no longer exist. We would be back to numbers that we had seen prior to Iraq. Those rates would have dropped dramatically. And so it's the nature of those connections that really is the critical thing. If you look at the work that we do in terms of studying effective treatment for suicidality. So we've got 2 clinical trials currently underway at Fort Carson in Colorado. It's the nature of the relationships that are established and maintained. Do we have mechanisms in place to maintain those relationships in effective fashion? The question that I ask when I look at that suicide data report data on they had a contact a month prior, the question that I ask is how long was it till the next appointment? So when they had that contact, was the next appointment scheduled 6 weeks out? Was that the problem? Or was the next appointment scheduled a week out and they didn't keep the appointment? My concern is that from the individuals that I talk with that we treat, from the individuals that I know, the families, surviving family members of those that have died, oftentimes it's an issue of the system getting in the way of being able to keep an appointment, get an appointment, or get to an appointment. That those individuals that are connected need to be connected to people, they need to be connected to the same people, they need to be continued frequently in treatment. They don't need to receive care every 6 weeks. They're going to need more frequent care. It's those kinds of questions that I think we need to be asking is how do we connect, how do we keep them there, not necessarily are we getting them there. I think we're doing a better job of getting people there. I think the Army data, the military data reveals that. I think that the VA data reveals that. But ultimately the question is, how do we keep them engaged? How do we keep them involved? Have we made the system accessible so that they can continue to be a part of the treatment cycle? That really is my core concern.
Anybody got anything they'd like to add to that? Doctor?
I would say it would be very interesting, and I did not read the report. It would be very interesting to see how many of these people had done multiple deployments and multiple tours. In my testimony, I wrote of a situation which I hope everyone will take a look at. The fact that people, veterans of the Guard and Reserve who have come to our state, who are already rated service-connected at 70 or 80% for mental health issues, have been told, and they do, sign a waiver to stop their disability checks and then sign up for another deployment. I have had some very difficult times for these people who already are rated, which is not an easy thing to do, and yet they sign away their checks. And it is well known because there's already a form for it. So they are deployed back to the combat zones, thinking that when they return, they're going to get their disability checks, are just going to smooth, and they'll have their disability rating. They don't realize what they jeopardize, nor do the people at the National Guard and Reserve levels understand what this is all about. But when you take someone who has been deployed multiple times, and in our state, it varies from services. I myself am an Air Force veteran, so many deployments by the Air Force are not a whole year long. But the issue is, they come home, they just get reacquainted with their family or the community, and then they're gone again. And there's really no time for a decompression kind of experience where they can learn to be back in the community again before they have to gear up. And I do feel that some of this is they never gear down. They're always as if the adrenaline is as if they are in the combat zones. And many families are at a loss. They think they're going to welcome them home, and they find that the individual is not, that's not where it's at for them. So these multiple deployments, using people that already have disabilities to redeploy to the combat zones, that has to stop. It's just incomprehensible to me. I mean, as a military member, when I leave my squadron, it was probably the saddest day of my life. That was me. I wanted to go back, and somebody did offer me a chance to go back, and I could have signed my life away and gone back but I knew that I couldn't do the work. So you have a group of people right now who'll do, some of them will do anything to get back because of the jobs, because of the feelings that this is a very important job that they're doing. So this is not a VA thing, but we are left, all of us in the veteran community are left to deal with these situations.
Thank you very much. Mr. Michaud?
Thank you, Mr. Chairman. Dr. Schwartz, first of all, thank you for your continued service to our veterans and their families. Really appreciate it. You stated in your testimony that serving veterans is a shared responsibility with state and the federal government, and I agree with you, and I also believe that community needs to be involved as well. Can you elaborate a little bit more on the barriers that you have encountered while seeking to partner with the Department of Veterans Affairs, as well as have you sought out other federal agencies, and if you have, how has that relationship been?
I think the VA has been operating on the notion that they have to do it all. And with the new hostilities and the heavy use of our Guard and Reserves, the real true citizen soldiers, so they have developed programs which are their counterparts in the states or do not even know about. There is very little dialogue about, for example, I'll just give you, they create a program where they are working with the homeless. Well, I have 380 homeless people. I have the most homeless people in the state of Connecticut, second only in the nation to California. But the issue is the kind of dialogue we have, especially over some of the programs, the kind of dialogue, if they're going to start a new program to assist veterans, I do believe that VA has to at least talk to the state. If they're building a facility for assisted living in the state of Connecticut, and they really have the Commissioner of Mental Health and Addiction Services and I had no idea. It's being built on the premises of Newington VA. We had no idea that this was going on. However, it does affect the state, and I think that's one way. But the other thing, and let me be very clear, there are some really good models of how it works. For example, my substance abuse treatment programs has 75 beds. The VA at Newington has a 21-day program. So all of my initial people in the program go to the 21-day program at Newington. They stay in a residential mode with us, and after they commit, because we think maybe you need a little more than 21 days, especially with some of our veterans, then they work with my clinical staff, and they can stay up to 6 months, because what we do is, as we work with them on their sobriety, we also work with them in getting back into the community. I'm very proud to say, yes, we have a lot of people, but last year over 150 veterans left my facility with a job and a place to live. So some of them, and I would also say we have over 500 veterans of Iraq and Afghanistan have gone through this program in my time, that's 10 years. But the issue here is there is so much more that needs to be done besides calling or giving. You need to have that interaction. Perfect handoff. I talked about the military support program. We have expanded that program in the state of Connecticut to all veterans and all veteran families because of our concern about suicide. So that if somebody can call even in the middle of the night and get a friendly voice, we also have veteran workers standing by as crisis intervention. And we're not the only state. Massachusetts and other states are doing wonderful work along these lines. But it's the beginning. It's not, just as was mentioned, you want somebody there that they can trust and talk to. The therapeutic alliance does not necessarily happen with the VA, because in the middle of the night you can't call your VA clinician. You can't talk to them. Families sometimes can't even talk to them because of the HIPAA laws. So if any of our clinicians in the community find that this is a little over their head, they will make the referral to the appropriate place, and many of them are. Many of the veterans are referred to the VA. But at least it's almost like a triage at the local level, and the handoff that they get is a little personalized because it's not like you're calling an 800 number. And I would also add that some of the suicides that we have seen, don't think it's just men. I think some of the saddest things for me is that women are killing themselves too, women with children. And that really brought it to the forefront in our state. So the VA has to, in my testimony, I do say that Secretary Shinseki has acknowledged this. The problem is, this was noted in other testimony, that mindset has not filtered down to the people at the administrative local levels. I have a wonderful relation with my homeless outreach people at the VA level because we touch people. We're not shuffling papers. I know I had to learn how to do that too, but the point is, the people that touch people are deeply, deeply ingrained in making it happen. So we have a new challenge here, and we have to challenge the status quo and begin to create new models because we're not going backwards. This is the way America's going to do war in the future. And these are the Guard and Reserve are going to be your clients, my clients.
Thank you very much. And I'll recognize myself for 5 minutes. First question is for Mr. Rudd. You mentioned in your testimony that in order to reduce wait times and increase access to mental health care, the VA may need to explore partnerships with private community providers. What do you believe is the biggest obstacle preventing the VA from doing this?
You know, I'm really not sure what the biggest obstacle is outside of the simple fact that it's not been done, that it's a non-traditional approach, that the way that we've done this, I think, over the years, particularly since the start of these wars, is that we have made the VA larger. I think the evidence would suggest that the VA does not need to continue to get larger. That I was not overly encouraged when I read the response of that they've hired 1,000 individuals in some of these numbers. I don't see that as the solution. I think the solution is that we look at partnerships like TRICARE partnering, which is a wonderful partner approach, primarily because those providers are already in those small communities. Those providers are available, accessible in those small communities. But what that means is shifting funding, shifting money to a non-traditional model, and I think that's personally the way to go. I think that's how you connect people to people at a local level so that individuals don't have to travel great distances.
Very good. Anyone else wish to comment on this subject matter?
I would just comment, I think from DAV's perspective, we have a little bit of a different thought on that. We're definitely invested in wanting to make sure that the VA receives the proper funding and what they need to do their job. I mean, they're the primary source of government response to this issue, you know, to when veterans are coming home and need assistance. They're going to be there for the long term, and I think VA's long-term relationships with its patients are extremely important in providing really high-quality care. And not to say that VA doesn't have to partner with the community, and in these cases we've certainly found, you know, there's just been continued issues with access. But at the same time, I think we really want to see VA resolve some of the issues that we know have been identified by the GAO, by the Office of Inspector General, and VA itself. So what is the problem? Where is the logjam that they can't overcome those obstacles within the system to be more efficient and spend the money which has been provided and authorized by this committee and by Congress in significant amounts to really care for these people with the specialized treatment and services that they have, you know, really they're second to none, and especially with these coexisting disorders. But they do, I think, need to look outside the box given the issues that we're, you know, they continue to experience with access. So, but I'd like to see VA really step up to the plate. I know there's a lot of people that are trying hard, but you know, the time has come where it's just absolutely critical given all of these reports with, you know, the suicide and various issues we continue to hear about.
Thank you very much. Dr. Swartz, in your testimony you make a valuable point. The federal, state, and local initiatives should be coordinated. I agree with you, and I'm a proponent of the one-stop shop models. How do you believe that this integration can be best facilitated?
I think there are models in the federal government, and I know I didn't respond to the question adequately. You know, with the public health, HHS gives grants. They have local level coordination across states of certain programs that are funded. I see that VA will always be, in reference to Joy Elam's statement, VA will always be the crown jewel. But the needs of the veterans today are much different. For example, when I was in the military, and I'm going to age myself, I was not allowed to be married. Then they allowed us to be married, and when you had a child, you had to leave the military. Now, almost 83% of the people on active duty have families, and 58% of the Guard and Reserve, all of them, the family, especially those with this generation, and was referred to the camaraderie, the sense of camaraderie, the need to be with each other. But the family unit is more important now than it has ever. And VA is not authorized across the board to help these families. So that's why other programs have evolved. So the most important thing with these models is, I would say, I'm not telling you to just be dropping money everywhere, but that we would have grants to do the outreach, to connect people. Excuse me. VA has a large grant and per diem program for state homes. I have one. There is quality assurance that is built into that program, that could be built into the mental health program. But you are not going to, as long as we rely on the Guard and Reserve, it is too long for someone to drive. And we did a survey of our veterans. If they had to drive more than 30 minutes to a source for anything, it was too far. I have to drive, it's 65 miles from my home to the VA hospital. And if you had to take public transportation in the state of Connecticut, it would take you 2 days on public transportation. So accessibility is much more than eligibility. Accessibility is having someone, a private clinician. That is not the model of the VA, but that is a model that can be built using clinicians. This worked very well for the state of Connecticut after 9/11. I did not mention this, but we have had over 3,500, since this program we have had over 3,500 clients. I would say a third of them have been referred to VA for care, but most of them are in treatment in the homes, in the towns where they live. And the reimbursement, if it's not coming from the any other third-party reimbursement, the state of Connecticut pays these therapists. Many of them do, actually, I have to say, do this for pro bono because they want to help. But this is an excellent example of how it can go to where it needs to be. Thank you.
Thank you very much. I yield back, Mr. Chairman.
Thank you very much, Ms. Brownlee.
Thank you, Mr. Chair. I appreciate this. I had a question actually for Dr. Rudd, and in your testimony you mentioned about access to service, but also transition services for people transitioning out of the military. And I recently, when I assigned to the committee, I decided to visit all the veteran facilities in my district, and I visited the transition center at Naval Base Ventura County. And I was actually very, very impressed by what they are doing there and their focused attention, and a program that is very comprehensive, that goes on for a pretty long period of time to prepare them for this kind of transition. And so I'm really wondering, how we can capture these best practices when we see a good facility like this doing good work, how we can create new models and best practices to replicate better than we are doing throughout the country.
Well, I agree with you. I think there's some very nice models out there. I think a part of the problem is that you see one side or the other doing a nice effort. but not both simultaneously. So if you look at the death of Russell Shirley as an example, he was, because of the DUI, he was referred for treatment, substance abuse treatment on the active Army side, which when his discharge was processing was discontinued. As a part of the discharge process. It's those little things that make the big difference. It's whether or not somebody actually gets into the service, gets connected with a provider in these critical moments. And so oftentimes those are non-clinical kinds of issues. Those are issues with commanders, those are issues with administrators, not with the clinical staff. And when I reference that I don't believe this is a clinical problem, I really don't believe this is a clinical problem. I believe it's how we shepherd people through the system that are at high risk with non-clinical procedures. I think it's how we end up connecting them and then maintaining them there that is the problem. So I think a part of the difficulty in Russell Shirley's death was the fact that the company commander disconnected him from treatment, didn't connect him to transition services. Those are the kind of things that we need to find policies and implement that can be maintained, monitored, so we can effectively manage these people as we move them through the system. I think more attention has to be focused there, not at the transition center, but how do you get somebody in the door? And then how do you monitor and make sure that they stay there and they stay all the way through? And then if they disengage, what are the procedures for re-engaging them if they disengage? Those are the kind of things I think ultimately that will save lives.
And are we doing anything vis-a-vis accountability to look at these transition centers and others to see identifying people who are in trouble after transition and looking specifically at the transitioning that they have or have not received?
Well, I think that we've started the process. I mean, I think one of the tragedies of this is that it has taken 10, 11 years of war, many deaths, and many tragic suicides for this to happen, that we're now putting systems in place to be able to look at this effectively. I mean, I think the work that Dr. Kemp does genuinely is historic, but it should have happened decades ago. We should have had a system in place that we can monitor, manage, and understand how many people are dying by suicide, and we can accurately understand the number of events. And we're still only at 21 states that have accurate data, with the two largest states without accurate data at this point. And so I think we're just building the system. That's a wonderful contribution, but it really is just a foundation. So I think that when we get the foundation set, a part of what we have to layer in is some general patience with the idea that we don't have the infrastructure in place to do the very things you're asking. And I think that we need to ask that question repeatedly to get the infrastructure in place. We've got some of that now on the suicide front, but it has to happen in so many different layers. And that is very much a non-clinical problem. I mean, that very much is a management problem. And that's where I think making the VA bigger creates bigger challenges, because the management of big systems is tough. And so I think that's where we need to think a little bit creatively about how to do this.
Thank you, sir.
Thank you. Dr. Benishek.
Thank you, Mr. Chairman. Dr. Schultz, you said a couple of things earlier that sort of intrigued me, and I want to ask you about them a little bit more. You said that there was a need for the private sector mental health care because calling the VA, there's no access to people at the VA at night.
Right.
So the Veteran Affairs mental health doesn't have any on-call person that they can call?
Well, they do have an on-call person, but in the sense of mental health care, it is very essential that they find somebody that's responsive, just not somebody in the emergency room.
Right.
And in large states, they may not even know this person. So the accessibility of trying to contact your mental health provider in the evening is not standard. We have had, by the population of veterans that I have also use VA, trying to get a hold of the person that is their primary treater for mental health. We do not have access to the primary care provider.
But you're saying in the private sector,
they do.
You do.
I mean, I just for example, my master's is in psychiatric nursing, and so a lot of clinical nurse specialists are in private practice, and when they are not available, any psychiatrist They always have someone, or psychologist, always has coverage. You have you can call into your provider, get a hold of them if it's a crisis, and if they're on vacation, you will get somebody that they have told you will be covering for them.
Right.
So it's
Yeah.
there. It's there. It's somebody that you can really talk to.
Well, I'm just sort of amazed by the fact that the VA doesn't have that same sort of a system, and
It's a large,
disappointed to hear that, frankly.
it's a large system, and as was very well described, the larger the system gets, there's another thing, and I bring this, it's in my testimony. The soldiers of today expect their treaters to be competent, to understand them, to respect them, and they expect the same kind of care they would if they were going to a private provider, which means if I'm having trouble right now, I want to call my psychiatrist, I want to call the office,
Right.
and I want to talk to them, or maybe I need to go somewhere. This is not available
Right.
on an individual basis. The large system may respond. But if I have somebody in crisis and I get somebody at the VA that does not know this patient,
Right.
they're not going to be as helpful.
Right. No, I completely understand. Mr. Ibsen?
I think, I think the concept of partnership was discussed earlier, and I think we have to recognize that there is a national shortage of mental health providers. What I think Linda had indicated earlier, and I hope VA is moving away from, is the sense that we own this issue alone. I think the opportunity is there for community and VA to work closely together, and I hope that's the direction we'll see.
Dr. Schwartz, we said on one other thing, that is people waive their mental health disability to return to deployment.
Yes.
How often does that happen?
I'm a very small state, but I know at least 5 cases of this happening. Because what happens is when they come back, they expect those checks to just keep rolling, and then they come to me because I have service officers, and we have to tell them the sad truth that you just signed away. When you sign and you say you're good to go, you stop your check. It says I am fit for duty.
Right.
So if they're deployed and they come back and think they're going to get that, they have not been really, they were not well informed that they're signing away something that is very important, but at the same time it is incomprehensible to me. I served 16 years in the United States Air Force. It is incomprehensible to me that they would ask someone who was already compromised to, at any rate, unless it was like somebody really unique. But these people are choosing to go back into the military because it's a job and they feel as if they belong there. So you put that knowledge into the fact that we're going to have a drawdown of tens of thousands of people who feel that's where they belong.
Well, no, it just worries me that we're taking people that have,
Yes, it worries me too.
related mental illness to
they
the
can get
deployment,
themselves
or
into
they're
a lot of
waiving
trouble.
that. I don't even know that we should be allowing that to occur.
I would hope that this committee would really look at that and work with people to stop that.
Thank you for your comments. I'm out of time.
Thank you, Doctor. Ms. Negrete McLeod. Mr. Runyon. Mr. Kaufman. Mr. Michaud, you got any more questions? Okay, thank you very much for being here. We do have some additional questions we'd like to present to you for the record. Thank you so much for what you do. I look forward to a continued relationship with each of you on this very important issue, and you're excused. I'd like to invite our second panel to the witness table. Joining us from the department is the Honorable Dr. Robert Petzel. Dr. Petzel, thank you for making your way through traffic and all kinds of security issues to be here. He's the Undersecretary for Health for the Department of Veterans Affairs. He's accompanied today by Mary Schoen, Director of the Office of Mental Health Operations, Dr. Sonia Batten, Deputy Chief Consultant for Specialty Mental Health, and Dr. Janet Kemp, Director of Suicide Prevention and Community Engagement for the National Mental Health Program. We thank you all for joining us today, and Dr. Petzel, you are recognized to proceed with your testimony.
Good morning, Chairman Miller, Ranking Member Michaud, and the committee members. I appreciate the opportunity to come here to discuss VA's comprehensive mental health care and services for our nation's veterans. I'm accompanied today, as the chairman indicated, by Dr. Mary Schoen, Dr. Sonia Batten, and Dr. Janet Kemp. Since early 2009, VA has been transforming and expanding its mental health care delivery system. We've improved our services for veterans, but we know that there is much more work to be done. My written testimony has more detailed information, and I would submit that for the record, without objection. This morning, I'll summarize these remarks and update you on our major accomplishments. As the President stated last night, we will keep faith with our veterans, investing in world-class care, including mental health care for our wounded warriors, supporting our military families, and giving our veterans the benefits, education, and job opportunities that they have earned. We're progressively increasing veterans' access to mental health care by working closely with our federal partners to implement the President's executive order to improve access to mental health services for veterans, service members, and military families, as well as implementing the 2013 National Defense Authorization Act. We know these changes require investment. Last year, VA announced the ambitious goal to hire 1,600 new mental health care clinical providers and 300 administrative support staff. As of January 29, 2013, VA has hired 1,058 clinical providers and 223 of the administrative staff. We're on track to meet the requirements of the executive order and have these positions filled by June 30th of 2013. VA has many entry points for care, including 152 medical centers, 821 community-based outpatient clinics, 300 vet centers, 70 vet center vans, and the VA's crisis line, to name but a few. We have also expanded access to care by leveraging technology, telehealth, phone calls, secure messaging, online tools, mobile applications, and outreach efforts, mental health integration into primary care, community partnerships, and academic affiliations. Outpatient visits have increased by over 17 million in 2012. The number of veterans receiving specialized mental health treatment rose to 1.3 million in 2012 from 927,000 in 2006. In part, this is because our primary care clinicians proactively screen veterans for depression, PTSD, problem drinking, and military sexual trauma to help these veterans actually receive the treatment that they need. We're also refining how we measure access to ensure we accurately reflect the timeliness of the care we provide. VA is updating scheduling practices, strengthening its performance measures, and changing timeliness measures to best track new and existing patient access times. We will continue to measure performance and hold employees and leadership accountable to ensure that the resources are devoted where they're needed for the benefit of America's veterans. VA has been working with partners to address access and care delivery gaps. In response to the executive order, VA is collaborating with Health and Human Services to establish 15 pilots using community-based health clinics and mental health clinics. VA is also partnering with DoD to advance a coordinated public health model to improve access, quality, and effectiveness of our mental health services through an integrated mental health strategy. VA is committed to ensuring the safety of our veterans. Even one veteran suicide is one too many. July 25, 2012 marked 5 years since the establishment of the Veteran Crisis Hotline. This offers 24/7 emergency assistance. Last year, this crisis hotline received more than 193,000 calls, resulting in over 6,400 rescues, people rescued from harming themselves or someone else. Earlier this month, VA released a suicide report developed collaboratively with the states. This report includes data on prevalence and characteristics of suicide amongst veterans, including those veterans that are not treated within the VA. The report provides us with valuable information, as we alluded to earlier, to identify populations that need targeted interventions, such as women and Vietnam veterans. Moreover, it identifies opportunities to train providers who care for veterans in non-mental health settings. The report makes clear that although there is more work to be done, we are making a difference. There's a decrease in suicide attempts by veterans getting care within the VA. Calls to the crisis hotline are becoming less acute, also demonstrating that the VA's early intervention appears to be working. Mr. Chairman, we know our work to improve the delivery of mental health services to veterans will never be done, and there is much more to do. We appreciate your support and encouragement in identifying and resolving challenges as we find new ways to care for this nation's veterans. My colleagues and I are prepared to respond to any questions you may have.
Thank you very much. At the end, and I didn't have a chance to run back to your statement, but one of your last comments was that the number of calls coming into the crisis line were decreasing.
No, actually, sir, not the number of calls that were decreasing, the intensity of the calls. The patients that are calling now are less acute than they were when we first developed the crisis line, indicating.
And again, so you say that's a success.
I'm saying that that's an indication of the fact that we are having some impact.
Could they be going somewhere else other than your crisis line?
We don't think so. The calls are, if anything, increasing. We're seeing the volume. We're not seeing the acuity.
Because we had testimony from the Connecticut State Director about having 5,000 veterans on their rolls. I mean, could they be going to their mental health providers? I mean, could they be going somewhere else?
Let me ask Jan Kemp, who runs that hotline, to comment. Dr. Kemp.
Yeah, we looked extensively at the number of people who are calling the crisis line and what they look like and where they're coming from. Our volumes continue to increase. We think our messaging is out there. We're reaching people. We are making an increased number of referrals. So when those people call the crisis line, we're able to refer them primarily to VA mental health providers through their suicide prevention coordinators. But we do also have partnerships with other organizations for those veterans who don't want to go to the VA, such as Wounded Warriors and Give an Hour and Vets for Vets. So we have lots of options to give veterans referrals to, and we're proud of those. What's going down, however, is the number of rescues that we're having to call. So people hopefully, and we believe, are calling earlier in their sort of crisis trajectory process, that we're able to get them help sooner before it comes to the point where they've already taken pills or they're holding a gun to their head. That was our intent. That was one of the reasons why we sort of changed our messaging campaign halfway through the stream. We changed the name of it. We want to get people sooner. We think we're doing that.
Dr. Petzl, you, in your opening statement, and I agree with this, our ultimate desired outcome is a healthy veteran. The problem is, after you said that, the focus, I think, on the majority of your testimony was processes, number of people hired, numbers, and I think the most important number is how many veterans are getting healthy or healthier or helped. And so I think this committee would like to know, how do you quantify whether or not that veteran is, it's easy to quantify a number of people hired. How do you quantify whether the veteran is being helped or is getting healthy?
Well, Mr. Chairman, we would agree with you that the important data is how have we helped veterans. And we mentioned in the opening statement, and we'll elaborate on that, several instances. Number one is the crisis line data. No question about the fact that that indicates that there is some impact on veterans with mental health problems of the programs that we're involved in. Number two is the suicide data. The suicide data is going to become an important part of us evaluating how well we are doing. And there is an indication in that suicide data that indeed we are having an impact if people are being treated in the VA. The third thing is,
But being treated, there's a difference though, and I apologize, but being treated is one thing. How many of them are becoming healthy again?
well, if the suicide rate is declining, if there are fewer suicide attempts, if there's a decreased need to rescue, that tells me that those people are getting better.
But those are not every person who has a mental health issue is a subject to a suicide attempt or an actual suicide. They may continue with mental health and depression issues for a long time. So basing everything off of in the crisis line and the suicide numbers supposedly going down, I don't, again, how do you quantify that a veteran suffering from depression or PTSD is getting better?
Let's take the example, Mr. Chairman, of PTSD. We can evaluate the symptoms in a patient when they initially present with PTSD, and they may go through cognitive behavior therapy or another evidence-based therapy, and subsequently they are evaluated for the presence of the symptoms related to PTSD. And we have good evidence in the literature that people that go through that program do indeed have less symptomatology associated with their PTSD and are better adjusted to living in society. There are many instances of the treatment protocols that we have where we can demonstrate the direct impact on those individuals that have been through that therapy.
Is there a disincentive for a veteran who has been rated for PTSD to show improvement?
I don't believe that there is. I believe that people that are suffering from PTSD do want to have that PTSD treated and do want to go through therapy and do want to make a better adjustment to their living circumstances. No.
Okay. Thank you, Mr. Michaud.
Thank you, Mr. Chairman. Thank you, Undersecretary, for being here today. Mr. Ibsen mentioned in his testimony about Central Office doing a survey of the clinicians as far as the best clinical judgment. Is that survey completed, and could you share it with the committee? And my other question is, you mentioned the President's executive order, and it's going to establish 15 pilot sites. And we heard earlier testimony today, when you look at the huge influx of soldiers that are going to be coming back, and 40% of are in rural areas. How were the locations of those pilot sites determined, and do you take into consideration the problem we're facing in rural areas?
Thank you, Congressman Michaud. I'm going to have to talk with Ralph Ibsen about the survey that he referred to. I'm not quite sure which one he meant. I know that more than a year ago, what really touched off the eventual feeling that we had to hire additional mental health workers was a survey of our mental health providers as to whether or not there was adequate staffing. And that may be what he's referring to, but I will talk with him after we finish with the hearing, and we will then get back to you. In terms of the pilots, the 15 sites were selected. They were selected based upon the desire of a local network or hospital to participate, and a need as identified often by how rural the areas were. There's one urban center where we're doing this in Atlanta to get a feeling for what that might be like, because there are many, many community mental health clinics in the Atlanta area. I want to mention just tangentially to the pilots that we have been participating with community mental health centers in certain parts of the country prior to the pilots. In Montana, there is a network of community mental health centers that are providing care to veterans in that phenomenally remote state where we are not able to provide mental health providers in each one of the communities. We think that this is going to be a viable alternative in the future to us cooperating in the community with providing care in these, again, remote rural areas.
Okay. On the suicides, my understanding the VA now has a memorandum of understanding with all 50 states to share the suicide data. And it's all, we heard also earlier this morning the two large states, I think it's Texas and California, has not submitted that information. Are there any other states that have not submitted that information? Because my concern being is when you look at the increase in suicide rates that went from 18 to 22, and that is, to me, that's the low number, because there are a lot more suicides, I believe, out there that are not being reported. So are there any other states out there that have not reported?
I would ask Dr. Kemp, who runs the suicide program, to comment on that. I do not know the answer.
We now have agreements with all states that they will. We have gotten data from both Texas and California since the report came out. There's a couple of states that we're still working with over privacy issues and how we're going to share the data, and I'm confident that we'll get those soon.
Thank you. Earlier today, we also heard, I think it was actually Mr. Ibsen, I believe, talk about, the clinicians within the VA. They have to meet certain performance requirements set out by, central office. Last year, or the year, I think it was last year, we also heard from a former VA employee that worked in a facility in, I believe it was New Hampshire, pretty much said the same thing, that they have a certain performance criteria they have to deal with, that they do not feel that they can provide the services to our veterans the way they should be providing it, because it's trying to just get them through the system, and that's a concern that I have. And can you talk about other performance requirements set for the clinicians?
Thank you, Congressman Michaud. Yes, there are, and there is a tension and a balance between having the time available and the need to provide direct clinical care, and on the other hand, the need to document what's been done, and the need to provide information in terms of performance measures sometimes for us to be able to answer the chairman's question about, are we having an impact on patients? And oftentimes the performance measures, particularly outside of mental health in the medical health system, are a very important part of our being able to say, yes, we have had an impact. We have helped this patient avoid cardiac disease or whatever. So it is important to have performance measures, and I think it's incumbent on us as the leaders to make sure that there's the proper balance between time available to do clinical care and the necessity of meeting performance measures. And just an example, one of them would be a reminder will pop up, you need to immunize this patient for influenza. And that's a reminder that's got to be satisfied, and there are a number of other kinds of reminders that need to be satisfied to do those things.
Do you provide the committee with those performance standards that they have to meet?
Yes, we can. Okay, we can. Yes, sir.
I think about your delay that it was probably a lengthy.
Congressman, it's not so much as lengthy. It varies from the kind of clinical setting that one is in. But we can do this, yes.
How does reminding a provider that somebody needs an immunization help them get better mentally? I mean, that's what we're focused on at that point. It's providing mental health to the veteran. And so clinically, I guess I understand if he needs a flu shot, but that's not what he's there for.
I'm sorry, Mr. Chairman. I was trying to give an example to the congressman of the things that we hear clinicians complaining about in terms of performance measures and clinical reminders. There are clinical reminders that are related to mental health, such as
No, I understand that. I'm just, just a question. I apologize. Mr. Runyon?
Thank you, Chairman. And some of my questions, I'm not even sure you can answer because, as Chairman Miller said, there's not a lot of data on what's happening day to day. My one question, Dr. Petzel, I do have, and it seems a lot of things we do specifically in the mental health field, is especially in the VA, and I think nationally too, because I don't know if we're there yet as a medical field. We're the balance of being reactive to being proactive a lot of times is way out of balance. And have you had any movement on trying to figure out how we can get in? Obviously, a lot of the PTSD that a lot of our veterans have is triggered at some point. It's there. Maybe we could have proactively got in front of that. Is there anything that you've been discussing or have out on the horizon that we can say that we're going to move in that direction so we don't have to wait till the last minute till there's a crisis?
That is an excellent question, Congressman Runyon, and I want to harken back to what Dr. Rudd said in terms of transition. Identifying all the patients that we see come out of the Department of Defense. They're soldiers, sailors, Air Force members, airmen, Marines, and we need the opportunity to interact with these people before they leave the service. The new mandated transition assistance program, I think, is going to give us that opportunity to both present and interview the individuals before they leave the service to identify those people who are at risk, who might have a previous problem, who might have a problem in transition, so that we can do what was referred to earlier as a hot transfer, a warm transfer between the Department of Defense, the Army, whatever it might be, and our VA healthcare system, so that these people don't fall through the cracks, so that we do get them into our system. We can do a very good job once we can get people into the system, and I think a major issue is providing for the right kind of transition, and that involves our being able to get at these individuals in this mandated transition assistance program. The second thing that I'd like to talk about in relationship to your question is another issue that came up, and that's establishing the kind of relationship with a patient so that they will tell you their story. I mean, there are certain, in our age population, 50 and over particularly, there are certain things that are associated with suicide, antecedents, so to speak. Substance misuse, pain, depression, maybe PTSD, life stressors. We need to have a relationship with that patient such that they will tell us about those. They will tell us their story, if you will, as opposed to the usual, is anything bothering you? No, nothing's bothering me. I think you've heard that interactions many, many times where it tends to be superficial and you don't really get the story. So getting at patients early through transition and developing the relationships where they will tell us when there are things that may be antecedents to suicide that are bothering them that we can act on, again, before there's a crisis.
Well, I think, and this is more of a statement than anything else, I think the bigger question is it's human nature to be secluded and not do that, but how statistically can we do with DOD data kind of figure out people that are in the same unit or that have been exposed to things like that? How can we proactively prod them, if you will, to, give us that information?
Well, certainly if we have access to their medical record with this integrated healthcare record that's being developed, we will be able to see those people that have had difficulty meeting their mortgages, that have a difficulty with substance misuse, that have had behavioral problems, etc. Those things are all triggers that would indicate to us this person needs to be evaluated, this person needs to be looked at closely. It's getting the information and the contact with the individual before they have the difficulty, as you pointed out, is the problem.
Thank you, Chairman. I yield back.
Dr. Petzlin, you may not be able to answer this today, but I'm going back to a testimony that was received last year about a study that was published in the Journal of Traumatic Stress on the utilization rates of veterans of Iraq and Afghanistan, found that less than 10% of the those newly diagnosed with PTSD received the recommended number and intensity of VA evidence-based treatment session within the first year of their diagnosis. Can you comment, is that gotten better than that?
I think you're right, Mr. Chairman. We're going to have to get back to the committee. I'm not familiar with the study, and I am not able to cite any specific evidence that that situation is different than what's in the study. So if we could, we would appreciate the opportunity to come back to you.
It was Dr. Karen Seal last year. I guess she testified in, I guess it was back in June, mid-June, but we'll get you the information. I just like to measure this year against last year.
I would also. Thank you.
Okay. Yes, sir. Ms. Brownlee.
Thank you, Mr. Chair. Before I ask a question, I'd like to ask you, I mentioned earlier that I recently visited some VA facilities, or most of the VA facilities in my district, the Oxnard CBOC, the Ventura Vet Center, and West Los Angeles Medical Center, which serves both Ventura vets as well as Los Angeles County vets. And as you know, it's the VA, the West LA Medical Center is the largest medical center in the country. And I'd just like to ask consent to include some written questions into the record for as a result, I have questions from those visits that I had in Ventura County as well as the West LA Medical Center. If I could submit those to the record on behalf of myself and Congressman Waxman, who also represents specifically the West LA Medical Center.
Without objection, and let the record show it's at the request of all members of this committee.
Thank you, Mr. Chair. And I just wanted to go back to, I think, listening to the testimony of the first panel. I think my sort of biggest takeaway from that testimony is looking at our models of delivery, noting that personalization, trust are essential components. Some of the testimony talked about comparing our delivery of vet services to private practice, meaning having contact with one individual, with one therapist who you can call 24/7 if needed. And I know that in your testimony that you talked about a lot of different programs which I believe are beneficial and are improving services, but it's still a concern to me if the personalization and trust is still built in to all of those programs. If you have to move from one program to the next program to the next program, I mean, that's one thing when you're having heart trouble and you're going to get an x-ray and moving from one situation to the next. But for mental health care services, that's, I believe, different. So in the spirit, I guess, of in any operation, in the spirit of sort of continuous improvement, are we looking down the road to sort of other models of delivery that would improve and enhance and bring our delivery of services perhaps closer to a private practice model?
The answer short is yes, Congresswoman Brownlee. But I mean, in a moment, I'm going to ask the other witnesses to comment on the remarks that Dr. Schwartz made, which are not the case. I can't speak for specifically what's going on in Connecticut, but our providers give their cell phone numbers, develop safety plans, etc., to individual patients, and they're available 24/7. In addition to the emergency room services that we have available in all of our medical centers and some of our larger clinics. That's just the way the system works. But as I said earlier, this developing of a relationship such that people will talk to you about what's going on, I think is a very important fundamental part. And we have a newly organized task force that Dr. Kemp is chairing that is going to look at how we can develop a different paradigm, if you will, for the way we deliver care to people that have chronic pain, sleep disorders, depression, etc., the things that have the greatest impact on suicide. The other care model that is growing rapidly in our system is the embedding of mental health providers into the primary care clinic or the PACT team. We now have, I believe, 593 places where that's actually happening, both in our medical centers and in our primary care clinics. And there you would have a nurse practitioner in mental health, perhaps a psychologist or a psychiatric social worker, who works with that primary care team and has a relationship back to the primary mental health group, a psychiatrist, etc. And that individual is able to manage the mental health issues in that panel of primary care patients. Therefore, that individual with mental health difficulties does not have to leave that clinic. All those services are available in that same arena. I think that's going to become a rapidly developing phenomena. The VA is a pioneer in that, but I think this is something you're going to see in other integrated delivery systems in the private sector. And then the last thing is telemental health, which is growing very rapidly and is the way that we're reaching, one of the ways we're reaching into the rural parts of this country to provide specialized mental health services.
And just and following up, there was also a comment about there were part of the testimony saying that the larger the VA becomes, there's the possibility, I guess I should say, of the quality and effectiveness of programs going down, and the notion of combining, partnering VA services with state services and I think community services to, again, I think to attract the right models of personalization and consistency and effectiveness. So, and what you were just suggesting and looking ahead to, are you also looking at greater community partnerships for our veterans?
Yes, we are, Congresswoman. That's what the 15 pilots are all about. That's what the network that we already have established in Montana is all about. And I think that there is going to be fruitful work to be done, particularly with the community mental health systems, which is another federally funded system around the country. You know, the difficulty in the private sector is they've got the same problems with shortages that everybody else does. When you look at a map of this country, there are 33 states where more than 25% of the population is underserved in terms of mental health, going all the way down the Intermountain country. There are 18 states in that area that have a shortage of mental health providers. There isn't a lot out there for us to contract with, and these community mental health clinics are one of the resources that we know, is there, and we do intend to exploit that.
And what about pipeline issues? I read, I think, in your testimony or in another report that, for example, psychiatrists, there's a shortage of psychiatrists, and I hear your concern about the limited amount of talent that's out there that we need to secure. And so are we looking towards that sort of pipeline issue to make sure that we do? That we do indeed. Am I over my time, Mr. Chair?
Yes, there's a clock.
I was looking at my clock here, and it says 3 minutes.
Yes,
so
with
I
a little
apologize.
red light, 3 minutes means you're 3 minutes over time.
I apologize.
May I take a moment, Mr. Chairman, to respond? In terms of the pipeline, a very important question. VA is the largest trainer of healthcare professionals in the country. We devote 6,400 trainee positions a year to mental health programs. 1,900 psychology training positions, mostly internships, the finishing year for a psychologist. 3,400 psychiatry residency positions, again, the largest trainer of psychiatrists in the country, and then 1,100 psychiatric social worker positions. We added last year 220 positions to that, all of them in these new concept teen care organizations, training positions in the PACT mental health embedded program, et cetera. So we are a big trainer. 70% of the people we recruit in psychiatry and psychology trained within the VA. It's a very important recruitment tool for us. But I think the committee must recognize the fact there is a shortage of psychiatrists in this country. There are not enough training positions for psychiatric residencies.
Thank you very much, Mr. Kaufman.
Thank you, Mr. Chairman. Dr. Petzel, in your testimony, you state that as of March 2012, VA was said to have 18,587 mental health providers. And by using an approved accounting methodology, VA currently has 19,743. But on April 19th, 2012, VA indicated it was adding 1,900 staff, quote, to an existing workforce of 20,590, unquote. Now, I'm not a mathematician, but the numbers show that VA is losing mental health professionals. So in what kind of fuzzy math is your current level of 19,743 a, quote, net increase, unquote, over the past level of 20,590?
Well, Congressman Kaufman, it's not fuzzy math. We had a process for assessing how many people we had on board in March that I would describe as incomplete. We took one database and applied it across the country and came up with a number that approximated 20,500, if I remember correctly. Over the summer, we have refined the way we count our onboard strength. And what we have discovered is that there were people not doing clinical work that were included in that 20,500. They were hired to do clinical work and research, and we were counting them 100% clinical. They were hired to do clinical work and education, and we were counting them as 100% clinical work. When we went back and used two separate databases and refined these educational and research components and administrative components out of that, we came back with an onboard strength in March of 18,587. Using that same methodology in November, we came to an onboard strength of 19,743, thus an increase of 1,156. Very clear. It's not fuzzy. It's not playing with the numbers. That's the fact.
I think it is odd that that VA would know exactly how many people, when asked, are providing work to help our veterans. And so, Dr. Petzel, has VA done anything to find out what your own mental health providers are saying about the work being done?
Yes, that's an excellent question. When we, this spring, have implemented our performance criteria for timeliness, the intention is to go out and do three things. One, look at the measures. Two, survey veterans as to whether or not they had timely access, as well as other satisfaction-related questions. And three, to survey the staff. Are they able to provide timely access for their patients? Are they adequately staffed? Do they have enough people to do the work that they're being required? So yes, we are going to do it, and we will be doing that on a regular basis. That's part of evaluating whether or not we're accomplishing what we said we would accomplish in terms of access.
Great. Could you please provide a copy of the unadulterated results to the committee by the end of the day?
Well, this is something we're going to be doing this spring, Congressman.
But there was a recent survey done, was there not? Could you provide to the committee any recent surveys done in the last 12-month period on your providers in terms of what we just talked about?
Yes, we will.
Thank you very much. Mr. Chairman, I yield back.
Thank you very much, Mr. Schott. Any more questions? Dr. Petzel, thank you and the folks that have joined you for what you do. We all want to work together to resolve this issue. My last question, I guess, to you is what recommendations do you have for this committee that we can do to aid you in your quest to provide quality and timely mental health services to our veterans?
That's an excellent question. Thank you. One is facilitating our interactions with the community health centers, and I can't be specific, but I think that's an important part of the future. Two is helping us work with the private sector provider community where it's available to provide services in areas where we're not able to do that. And then three, I would add, as I mentioned earlier, and I don't know how this committee can influence it, but there is a real shortage of psychiatrists in this country and mental health training positions. And whatever can be done to help improve that, I think would benefit the veteran community.
I do find it quite interesting that you mentioned the shortage of providers several times in your testimony, yet you're almost exceeding your goals for hiring, and I'm like, what do you do that the private sector can't do that helps you fill those slots so quickly?
Thank you. That is also a very good question. Number one, our salaries are very competitive for nurses, for psychologists, and for social workers. Number two is it's a good place to have a career. It's a large organization. You can work in many different parts of the country, and you can do many different kinds of jobs. We do have, however, difficulty in psychiatry. I mean, I don't want to brush over that. Of all of the professions in mental health, the most difficult problem we're having is recruiting psychiatrists, and we have barely been able to recruit half of the new ones that we said we would wanted to do. And that's in spite of raising the salary quite substantially, providing incentives for recruitment bonuses, et cetera.
Okay, thank you very much. I would ask unanimous consent that all members would have 5 legislative days to revise and extend their remarks or add any extraneous material for the record. Without objection, so ordered. Thank you, everybody, for being here today. Thank you for both panels. This hearing is adjourned.